Hello, you are listening to 1 in 2, a Manchester Cancer Research podcast, brought to you by the University of Manchester and the Manchester Cancer Research Centre. With 1 in 2 of us receiving a cancer diagnosis at some point in our lifetime, it has never been more important for our research to improve the outcomes for people affected by cancer. I am your host, Sally Best, and throughout this series I'll be speaking with Manchester cancer researchers about their innovations, discoveries and projects that are changing the landscape of cancer detection and treatment. In this episode, we speak to Professor Matt Evison and patient Sally Hayton, a never smoker with ALK-positive lung cancer. We focus on overcoming the barriers to early detection in symptomatic lung cancer patients, specifically never smokers, spotlighting the Manchester self-referral chest X-ray service. We also hear Sally's cancer story, her experiences, and the barriers she faced in receiving her diagnosis. Hello everybody, welcome to another episode. It's actually our final episode of season 2 of 1 in 2, which is really sad, but we've maybe saved the best till last week. So season 2 obviously focused on lung cancer, and we've gone through quite a journey with it. And this episode I'm really excited about because we've got the wonderful Matt Evison and also a patient, and I think patients are so important in kind of tying everything together, really, and understanding where this kind of research that we've spoken about is, you know, it can sometimes seem quite nebulous, and then we have the patient here and understanding the end goal, really. So yeah, yay Sally, you're here. We've got another Sally as well, actually, guys, so don't get confused because it's Sally and Sally, but we'll do Sally B and Sally H maybe if we need to do direct stuff. But today we're going to be focusing on overcoming barriers to symptomatic lung cancer diagnosis and focusing on never smokers. So I'm just going to come to Matt first, just so you give us a bit of kind of, what's the word? Significance, context is the word, as to kind of why we're here today. So I'm wondering if you could introduce yourself, who you are, what you do.
Okay.
And by the way, everybody, Matt's on call today, so if we lose him, that is why.
So I'm a lung specialist, and my area of work is in lung cancer. So in the hospital setting, I see patients where there's a suspicion of lung cancer, and oversee the diagnostic tests around that. And I'm the Associate Medical Director for the Cancer Alliance, and I've had leadership roles in looking at innovations in lung cancer across the region over the last 5 or 6 years.
Amazing. And you went to uni here?
I did, yes.
What did you do? Good. What did you do? What did you study?
Medicine.
Oh, look at you go. Look at you go. Love that. You might have been taught by my dad. Amazing. Well, you've got a lot on your plate there. And what you're saying is, so you work on kind of a lung care pathway board throughout the Greater Manchester area.
Yeah.
Amazing. And then Sally, coming to you, I just wonder if you could introduce yourself and kind of give us a bit of information as to who you are and why you're here.
Yeah, so my name's Sally. I used to work as an occupational therapist and then worked in personnel in the NHS, and then went back to working as an occupational therapist in the NHS and in social care. I never ever thought that I would be advocating for never smoker lung cancer, because it never crossed my mind that I would get that.
Yeah.
And I think I've started advocating really because my consultant initially started to get me to tell my story to other junior doctors and medical students who were in her clinic. So yeah, that's where it all began. Also, Greater Manchester Cancer has patient voices and involves patients in decisions that are being made in relation to lung cancer and ask patients to comment on that. Mm-hmm. So I've become involved in the small lung community for Greater Manchester Cancer.
Amazing. Well, it's great to have a patient here, as I've said previously, advocating for this. And we've done kind of previous episodes on never smokers, but we've never had that patient voice, and it's something that I'm striving for, to have that representative. So thank you from the bottom of my heart and the bottom of everybody's heart for taking the time, because I know it's not an easy thing to communicate and a dialogue to have, and it kind of must bring up a lot of things from previously that you're having to talk about, but showing strength in this area is so formidable of you. So you have my kind of sincere thanks.
No, I'm happy to raise awareness.
Amazing.
Yeah, it's important.
And I'm just wondering, it'd be great to hear from you about your kind of diagnosis. So I'm wondering if you could be able to tell us about like when you were diagnosed with lung cancer and what type of lung cancer you have.
So I was diagnosed with stage 4 lung cancer in November 2013. And I've got, it's adenocarcinoma, non-small cell lung cancer, adenocarcinoma. And I was tested for a mutation, and I've got this mutation called the ALK mutation, which is ALK, so the ALK mutation. And I've smoked less than 10 cigarettes in my life, probably when I was about 16 or 17.
Yeah.
And I think my understanding is that if you smoke less than 100 cigarettes, you're classed as a never smoker.
Yeah, that is, it's quite a scary kind of thing to have faced, I guess. And that ALK positive that you mentioned, we actually recorded with Fabio Gomez early on in the series on ALK positive lung cancer. So for anybody that wants to have a bit more of an insight into the kind of the science behind it, I'd say that would definitely be a good episode to look back on. And I'm just going to come to you, Matt, and ask if you could explain kind of the incidence of lung cancer as a whole, and then this kind of percentile of lung cancers in never smokers. Because I think, again, for a lot of people, lung cancer in never smokers is quite a kind of an enigma. So I'm just wondering if you've got any stats.
Lung cancer's a horrible, horrible disease. It is the commonest cause of cancer death across the world. So sadly, around 2 million people die from lung cancer across the world every year. So it's a major, major health problem and challenge. In the UK, there's about 40,000 people that are diagnosed with lung cancer every year. About 35,000 die every year from lung cancer. And approximately 6,000 of those are in people that have never smoked.
Okay.
And that you're completely correct. That definition we use, if you've smoked less than 100 cigarettes in your life, then you'd be classified as being a lifelong never smoker. So if you just look at it on its own, it would make it the 8th commonest cancer death across the country.
Yeah. Yeah, so if that was considered as a kind of cancer on its own.
Yeah.
It's crazy. And seldom kind of talked about as well. So it's
such an important topic.
Yeah. So in terms of never smokers, what would be some of the symptoms that a never smoker with lung cancer might present with?
So this is a massive challenge.
Yeah.
In that there are certain symptoms, and not just restricted to lung cancer, but certain symptoms that are red flags and very well-known red flags. So from a lung perspective, if somebody coughs up blood, I think there's probably a relatively well understood that should be looked at. And if that happens to someone, quite frequently they will seek, they would go and see their GP, or they would get that checked out. But actually that only happens in a very small proportion of people who have lung cancer. And the other symptoms are exceptionally common.
Yeah.
So a cough. A cough is probably responsible, I think, for about 10% of all general practice consultations. So that volume is huge, absolutely huge. Actually, lung cancer is a very, very rare cause of cough. So there's the challenge, and I think what we'll discuss is how do you, we all will suffer from a cough at some point. We'll all get those symptoms. How do we investigate appropriately and diagnose appropriately at the earliest opportunity? So cough, breathlessness, pain anywhere around the chest, and that includes we've got to think about language when we say pain in the chest. Medically, we may know what we think by that.
Yeah.
But actually, to somebody else, that could just mean your chest is at the front.
Yeah.
Now, we could be talking about shoulder pain, back pain, anywhere across the upper part of the torso.
Yeah.
So pain, breathlessness, and cough, they're the kind of key common symptoms, I guess, that are centered around the chest. But equally, there can be much more general symptoms. So you could lose weight, you could go off your food, you could feel run down and tired. And really, lung cancer can present in any way.
Yeah.
So it's a difficult diagnosis.
Yeah, completely.
It is, and that's one of the reasons why, sadly, it can present very late.
Yeah.
And sometimes it has no symptoms.
Yeah. And I think it must be hard as well for patients to advocate for themselves, because with such an array of symptoms, you kind of think, well, this is, this could be anything.
Yeah.
I mean, a type A person may experience fatigue and being run down and a cough. And I don't know, but it might be easy to just kind of put it down to like, oh, I've got seasonal flu or something, and I just keep on catching things over and over again.
Yeah.
So that, consistent cough, and I think as well, you've spoken with, was it on the GM Cancer podcast with Steve Bland about the message that, you've got a cough for 3 weeks, you go to your GP. Absolutely non-negotiable. That is just what you do, and don't ever feel like you're kind of, misusing the health service, because that is the guidelines, right?
Yeah.
Okay, interesting. And then coming to you, Sally, I'm wondering if you could just give an overview of your journey from diagnosis to the treatment that you're receiving now, and also maybe just mentioning some of the symptoms that you were experiencing and are experiencing now, just to kind of raise awareness to the sort of things that you were looking out for.
So, explaining how I was diagnosed, really.
Yeah.
So, I started with a cough and went to my GP within 2 weeks of starting with a cough. Well, I think I'd had it for about 2 weeks and went to my GP, and he gave me some antibiotics. And he said, if your cough hasn't gone, come back in 2 weeks. So my cough still hadn't gone. So I went back 2 weeks later, and he gave me some different antibiotics. And again said, if your cough hasn't gone, please come back in 2 weeks. So I went back 2 weeks later, and he ordered a chest x-ray. And then he phoned me and said, I'm referring you under the 2-week rule to a lung cancer clinic because something's shown up on your chest x-ray. At this time, I must say, I was living just outside of Greater Manchester, so this didn't happen within Greater Manchester. So I went to the lung cancer clinic, went through numerous tests on the day. And I thought, well, why am I going to a lung cancer clinic? I've never smoked.
Yeah.
My parents didn't smoke. I've never lived with anybody who smoked. So I couldn't really understand why I was going to a lung cancer clinic, but I thought, well, this is what my GP's told me to do. I very rarely go to the doctor, so I will go to the lung cancer clinic. So on the day I went through numerous tests, and then having gone through these different tests, I saw the consultant respiratory physician who said to me that he thought I was an inappropriate referral. So he wouldn't refer me direct for a CT scan now because there were more urgent people coming through, but I would get a CT scan appointment in the future.
And was that, sorry to interject there, that inappropriate referral was down to the fact that you were a never smoker? Or...
Well, I think so. Yeah.
Okay.
Yeah. I mean, he didn't think, he thought what I'd got was a virus.
Okay.
And he thought I'd had a virus, and he said it can take up to 12 months for your cough to go.
Okay.
So I then went back and had the CT scan numerous weeks later when the appointment came through. And that showed that I'd got right middle lobe collapse. And I had a letter from him to say that I had got right middle lobe collapse, but that right middle lobe collapse was common in people in the late 40s living in that area. And he did say that they could do a bronchoscopy if I wanted it, but he didn't think that was appropriate.
Mm-hmm.
So I never saw him. I just got this letter. So I went back to the GP, and I did actually discuss with the GP and said, do you think I need a bronchoscopy? And he said, well, there's a lot of risks, and if they're saying you've got, they don't feel you need it, I wouldn't do it. So and I, nobody thought I needed it, so I didn't have it. Then I went back to the GP because the cough was continuing, and I was treated for acid reflux on 2 or 3 occasions and given medication for that. Then I was treated for asthma and given an inhaler. I mean, I wasn't breathless. I was coughing. I don't know whether asthma presents with coughing, but that was massive. I definitely wasn't breathless. And then I got really bad rib pain, and the GP referred me for a chest X-ray, and that came back and it was reported as normal. So I assumed from that, totally naively, that my right middle lobe had reinflated for some reason, and that my chest X-ray was now normal because it hadn't been normal when I'd first had it. Then I got shoulder pain, and I was told I got a frozen shoulder, and I went to physio and was given exercises for a frozen shoulder. And then I was treated with the hydrodilation technique for a frozen shoulder. And when I was having that, the radiologist said to me, "Oh, we need to do an X-ray, really." And I said, "Oh, well, I've just had one, and it's come back as normal." So now anybody says something's normal, I'm really questioning it. But I never thought at the time. I just assumed what I was being told was right. So then my shoulder resolved after that treatment. And then probably about 6 weeks later, I started to lose the sight in my right eye.
Okay.
One evening I thought, this seems different. And we got some friends round for a meal, and I couldn't see my partner's friend properly at the bottom of the table. And I thought, it just felt different. Went to work the next day and didn't really think too much of it. And then on the way home from work, I realised it was getting worse and called in at an optician. And they were just closing, but when I explained what was happening, they said, "Why haven't you come sooner?" So I thought, I've been working. So they looked at it and they thought that I'd got either a detached retina, or they said I could have something more sinister.
Okay.
So I asked if I could go. They said they could refer me to Rochdale, or they could refer me to, because now I was in Greater Manchester going for this appointment. And I said, I think I prefer to go to Manchester Eye Hospital, really. So they referred me to Manchester Eye Hospital, and I went there that evening. And by 9:30 at night, I got a consultant holding my hand saying, "I think you've got a tumour behind your eye. Can you come back and see the retinal specialist tomorrow?" So when the consultant started holding my hand, and having seen numerous doctors between sort of 6:30 and 9:30, I thought that something's going on here. So then I was referred the following day to the ocular oncology people in Liverpool. And so it was the Tuesday that I went to the eye hospital. The Wednesday I saw the eye consultant. Then the following Monday I was seeing this professor in oncology at Liverpool. And he said he thought it was a tumour. And I sort of pushed him and said, "Do you think it's a primary tumour or a secondary tumour?" He didn't want to say, but when I really pushed him, he said, "Well, if you're really pushing me, I will say I think it's a secondary tumour." So they did a biopsy on my eye the next day. And when the results of that came through, it showed that the primary was in my lung.
Okay.
Yeah. So, yeah. Do you want me?
Yeah. I mean...
So, Sally, how long was the time from
that's what I was going to
your
ask.
cough first starting? 11 months.
Yeah. So it was December 2012 that I started with the cough. And it was the 5th of November that I was at Manchester Eye Hospital. Yeah. So it was a few weeks after that I got the biopsy results back to say the primary was in my lung. Yeah. So...
I mean, it's quite a kind of treacherous tale, that, and very difficult. I can imagine, with repeated advice and different kind of scenarios and things. And was there any point at the start of that journey that you thought, this could be lung cancer, or did you just completely negate the fact that it could have been because you thought, I've never smoked, I can't get lung cancer?
I never thought it was lung cancer.
Yeah.
Never thought it was lung cancer at all. My partner said to me, you've not got you won't have lung cancer.
Yeah.
People I knew, a couple of people said, you won't have lung cancer.
Yeah.
I never thought I got lung cancer.
Yeah.
So I didn't, it just never, ever crossed my mind.
Yeah, it's crazy. And I mean, Matt, coming to you, would you class that as kind of a late diagnosis of lung cancer in a patient?
Well, yeah, there's clearly opportunities for an earlier diagnosis. It's a very harrowing story, isn't it?
Yeah.
It's for members of the public to hear that, those symptoms that everybody could relate to, a cough that just won't go away. They thought, well, my God, that could be lung cancer.
Yeah.
From a healthcare professional, and that's even from a respiratory specialist. Think, I see this all the time. I see cough, and I don't think this is lung cancer, and then find out actually this is lung cancer. So it's really harrowing, I think, on both sides, and the huge challenges. So 999 times out of 1,000, those symptoms like that will not be because of lung cancer, but one time they will be. And how do you make sure? How do you do everything possible to not have 11 months of delay in symptoms, and to find that one? That's what we've got to try and address.
Yeah, I think I felt let down because having worked for the NHS and social care, I just automatically assumed that a consultant respiratory physician would know what he was talking about. So I totally took on board what he'd said. If I know what I know now, it will be quite different. And another consultant has actually said to me, he said the only mistake you made was listening to a consultant. But I must say, having said that, I haven't heard similar stories to myself where people have got to see a consultant respiratory physician and been misdiagnosed. I've seen people have delays at their GP, and people not going to the GP. So I do think my situation is a bit different, and I hope it's a bit different. I mean, and I don't want to just put it down to the consultant respiratory physician, because the chest radiologist had written benign. And the clinical director of radiology has written needs bronchoscopy. And the chest radiologist, who's a consultant, had put a line through that and just put benign. So I think I've just been really unfortunate that there is human error within everything. And when it's within the health service, it's obviously it impacts on people's lives more.
And I think there's an educational piece there as well to understand, it's not just at the public level of you advocating for yourself and understanding that you only need lungs to get lung cancer. It's changing the mindset of people on the pathway as well. And I know you do work in that, so that, consultants, clinicians can understand that referral routes for patients aren't so clean cut that if you don't fulfill one criteria, you get put down a completely different path.
I think if I'd smoked, I would have got diagnosed earlier.
Which is really, really sad. And I'm sorry.
Because there wasn't a red flag for never smokers. There was the red flag for smokers.
There's been some evidence published in the last 12 to 18 months or so that has specifically looked at some of the barriers if you've never smoked to the diagnosis of lung cancer. And that is a very clear theme that it's easier to be reassured that there's an alternative explanation for those symptoms and for vigilance to drop if you've never smoked. And that's being reassured by healthcare professionals, more easily reassured by healthcare professionals, more easily reassured that those symptoms must be something else.
So, I mean, Matt, you're kind of pioneering this diagnosis of lung cancer at an earlier stage, and the symptomatic lung cancer with a focus on never smokers. Could you tell me a bit of an overview about the pilot that you've been running in self-referral chest x-rays? Because I know this kind of links into that more of a holistic approach and that early diagnosis piece. I
I guess that it begins with the story about chest x-rays, because chest x-rays have been around for a very long time. They get a bit of a bad name about their ability to diagnose things because there are some limitations, but equally there are some real advantages. So chest x-rays are very, very accessible. They're very quick to do, and we have resources within the healthcare system to deliver them really at a much bigger scale than we do. And as I say, the big challenge is that there are many, many, many people who have the common symptoms of lung cancer, for which the vast majority do not have lung cancer. So I guess one way to think about it is if there are 1,000 people that have a cough or a breathlessness or pain in their chest for 3 weeks or more, then 10 of them maybe will have lung cancer.
Yeah.
And a chest x-ray will pick out 8 of them. It will miss 2.
Okay.
And that's a really key message, that a normal chest x-ray doesn't fully exclude lung cancer, but it's equally very reassuring, because then the 990 normal chest x-rays, or that show something else, are truly normal. So it's a test that's there and accessible, and we could really utilize that to its maximal potential for people that have these common symptoms. And there will be that small number where actually the x-ray is abnormal and it needs further work. But there's a lot of people where you could think, actually, that's quite reassuring, and I might not do anything else unless the symptoms don't go away, or I might have a little period of trying a treatment for something, or always knowing that a normal x-ray doesn't fully exclude lung cancer, though it is reassuring. You take every individual case on its merit, and you've got to have that awareness. So I think chest x-rays are an important part of earlier diagnosis when you have symptoms that could be lung cancer. It's about getting that chest x-ray. And there's lots of ways to do that. You've mentioned education already, and that's on both for members of the public, education, for healthcare professionals, it's education. But I think it's really clear and I guess really tragic that there are real barriers to accessing something like a chest x-ray, or accessing the healthcare system for someone who has those symptoms. That can be, if you do smoke or you have smoked, you could feel that if you go to a doctor with a cough, then there could be a judgment of that.
Yeah.
If you haven't smoked, you could feel, why would I go with a cough? It's just a cough. Or I've had a cough before and it went away. Why would I do something this time? Or I've been with a cough and they just told me it would go away. I'll just get told the same thing. And some of the most tragic things we've kind of found in some of our insight work is the fear of, it's almost that person isn't worthy of being seen, and these symptoms aren't worthy. The public get flooded by this messaging that the NHS is overrun. And so why would I go with this? I'm just coughing. That's it. So there's lots and lots of barriers that could prevent somebody going to seek help. And we know that a person with a set of symptoms could go and see one healthcare professional and have a chest x-ray. They could go and see another healthcare professional and they wouldn't. That's human behavior and assessment of symptoms. So there's some variation in access. So in that context, if somebody was concerned about their symptoms, and in the right context, so if we keep saying this message, if you've coughed for 3 weeks or more, it needs investigating. Your breathing has changed for 3 weeks or more. Pain, 3 weeks or more. Yeah. It needs investigating. And generally, that's over the age of 40. That's the kind of guidance we have nationally. Then you should have a chest x-ray. And if that person was able to just go and have one without going to see their GP necessarily, then the data we have suggests there will definitely be a population of people that will have an x-ray that wouldn't have otherwise.
Yeah.
there's still people who want to go and see their GP, want to talk those things through, and that's right. It's not one or the other. But by providing an alternative route, then the total number of people that should have an X-ray should go up.
Yeah.
That's the theory. So we've been running this in a few areas across Greater Manchester, and it has very much played out like that. There's been very, very good uptake, so very high numbers, particularly when you compare it to other things that have been tried to try and increase the rate of X-rays. So there's been a very, very good attendance. We're now into the thousands of people that have been for X-rays.
Yeah.
And which is a real positive. And they are people that need a chest X-ray. We know that because of the symptoms they've reported.
Mm-hmm.
They are in line with the guidance that we have, the people that should have an X-ray. And like we know, 95% of them have a normal X-ray. And they get a letter back, as does their GP, to say, you've been for an X-ray. This is normal. That's very reassuring. Yeah. But if there are worrying symptoms, persistent symptoms, an X-ray isn't everything. You have to get those things checked out. And then in 5%, the chest X-rays isn't normal. So 3%, there's something else. There's another reason. And that X-ray gets looked at by a chest specialist. And so sometimes that's just a case of there's a chest problem that needs seeing in a chest clinic. It's not cancer. But it almost takes out some of those. That's straight into where you need to be. And in 2%, there's a suspicion of lung cancer. And it ultimately works out about 0.5%, just over 0.5% have lung cancer.
So I'm just going to interject with a couple of questions here, because you've mentioned the kind of the criteria that people are adhering to be able to go for this chest X-ray. What are some of those criteria? Is smoking within that?
No.
Okay, so that's great for starters.
Exactly. Yeah. And that's a huge, and it's got to be accompanied by the education. So if you have lungs, you can get lung cancer. The chances are exceptionally small. They really are. That's important. But as we were saying before, that 1 in 1,000, that one, there have to be the processes and systems in place so that one person gets access, gets a diagnosis quickly, as quick as can be, which will in turn give the very best chance of the best outcomes possible. So it's all symptom based. There is, again, national guidance is about age. It's over 40. And then it's about symptoms. So 3 weeks or more, cough, breathlessness, pain in the chest, back, shoulders, fatigue, weight loss, loss of appetite, those symptoms.
And then my other question was, how are these scans interpreted? Because you're obviously going to receive, you've said there that you've got thousands of patients that are being recruited, and you're hopefully going to see that increase in people that are coming for chest X-rays. All I can think is who's going to be reading all of these, and how are you dealing with the kind of sheer capacity of that?
Yeah, it's a good question, and radiology in general is. It is in a crisis in the NHS. So that's it's a consideration in any part of healthcare right now. I go back to say that chest X-rays are they're quick and also quick to look at and report, much more so than other more detailed scans. Equally, when COVID hit, chest X-rays dropped off completely. And there's been a horrible aftermath of COVID and lung cancer, because everything we've just said, get a cough, get it checked. Early diagnosis, early
get
symptoms.
A cough, stay the heck away.
From everybody.
Yeah.
Stay away,
Yeah.
don't do anything, stay at home.
Yeah.
And we have seen later presentation of lung cancer. And chest X-rays just went. And we're not back to where we were before. And that's got to be a key priority for us. So whenever you pilot new services, you put mechanisms in place to ensure robust reporting, things like that. So within this program, there's a dedicated reporting resource as part of the program. And so the results are very fast. And so someone can get reassurance very quickly. The vast majority of people can be reassured. It's very likely it saves GP appointments as well.
Yeah.
That could be in different ways. So someone may go and see their GP having had an X-ray. So that first appointment, the GP has a benefit of, you've got an X-ray. I know what that X-ray shows. I'd have to send you for one and bring you back. We can make a decision now what we do. Or having that X-ray and reassurance and being reassured by that, as long as those people are appropriately safety netted. So just because your X-ray is normal, asthma doesn't show up on an X-ray. If you've got symptoms that are worrying they're not getting better, it has to be checked out. Has to be. But, like I say, 999 of the 1,000, that cough will just go away. It'll be viral. It'll be something, just as we were talking about. It will be, and it will go away. But you've had the appropriate test to provide reassurance.
Yeah.
And you select out those, or you've got to go and look into it further.
Within this pilot, was there any AI that was integrated in terms of stratifying kind of patient scans?
So there's a lot of interest in AI in chest X-rays particularly at the moment. So there's a lot of evaluation for it. And NICE, the national body, has evaluated AI in chest X-rays quite recently, and is very much more work is needed to understand its role. So there's work going on in Greater Manchester, and that's to try and understand, does it improve diagnosis? We can miss things on an X-ray. The human eye can miss things on an X-ray. So if you had a human eye and a computer working together, does it improve diagnosis? And equally, we think one of the big things may be that if you do have thousands of X-rays, how do you pick out those few immediately and say that one's abnormal? So that person's got to get into a CT scan very quickly, and AI might have a role in doing that.
Amazing.
So it's all under evaluation.
Yeah, something to look forward to then, hopefully. And in terms of I'm just on the self-referral chest X-ray still. What are the results looking at like so far? Like, you've said that you've seen that stage shift in people being diagnosed early. Have you had any kind of feedback about people who, have used the service or anything like that?
Yes. Okay, so stage shift, we probably have to be a little careful in terminology. So lung cancer is split into stages, stage 1 through to stage 4. If wherever possible, if we can diagnose stage 1 lung cancer, if it's there and you can find it at stage 1, the treatments are very, very good and have very good long-term outcomes. It's quite rare to have symptoms at stage 1 lung cancer. You don't have nerves in your lungs. You can't feel your lungs. You can't know something's there. And the real way to catch early stage lung cancer is through screening. So someone has no symptoms, but you find an at-risk population and do a test that can pick it out. And that's a real stage shift, because normally about half of all patients with lung cancer present at an advanced stage. Whereas in lung cancer screening, about 80% are found at stage 1. So it's a huge stage shift. We're talking about symptomatic diagnosis. It's very difficult to know whether that would cause a stage shift. But what it's very likely to do is lead to an earlier diagnosis.
Right.
And it makes a massive difference. Days can matter with lung cancer, and somebody's health can deteriorate very quickly. And if someone's health is deteriorating, that then affects your ability to make a diagnosis or be well enough to have a biopsy, which can mean you can't personalize someone's tumor and understand what the best treatments are. Their health might not be sufficient enough for treatments. So an earlier diagnosis when someone has symptoms undoubtedly will mean that there's an opportunity for better outcomes because we're finding it earlier when someone's fitter. Whether it will cause a stage shift, I don't know.
Okay.
But there's been so much focus on lung cancer screening, and rightly, because it will make huge differences. But about 1 in 4, 1 in 5 people with lung cancer will be found through screening. That's 4 in 5, 3 in 4, 4 in 5 that won't. And we know there are real delays in those paths. And it's that very first, from the first symptoms. I think everyone's in the lung cancer community is quite united that that's the part where we've got so much improvements to make. And this self-referral X-ray is just one component of a bigger strategy.
Yeah.
But it does seem to, the biggest thing for me is that it brings people in that need an X-ray. It overcomes those barriers. The actual prevalence of lung cancer within that cohort is really small, as it is for all chest X-rays. So we have to deliver this at a really big scale to really start to see the benefits. So far our work has been demonstrating that it overcomes the barriers to attending and getting a chest X-ray, which it really appears to do. And now it's about how do we expand and try and make sure it's available for as many people as possible.
So some of the people that are attending, would they have you got any reports that they wouldn't have attended the GP? Yeah.
Of everything. I think it's everything in there. We can show that there are some people that came for that X-ray that have never contacted their GP and never would. Some that have contacted their GP and an X-ray wasn't part of the outcome. So we've kind of, all those barriers we talked about, it appears to overcome them all. And so for some people, it provides that alternative route to where we need to get to, while still maintaining everything else we've got, and the education on both sides. How important it is to go and see your GP if you've got that cough for 3 weeks or more. That is still a really important message. We're not saying it's that self-referral is the only route. It's not. Just for some, it might be.
Yeah. And I mean, Sally, you've, been at this stage of diagnosis, and I know you also work on kind of patient representative groups and communicating with them and understanding what's best for other never smokers. Would you and your cohort, speaking on behalf of them, if you're comfortable to, do you think some people would find this incentive helpful, and would it have been something that you were interested in that stage of your diagnosis?
Well, I think when I was diagnosed, I was totally unaware that never smokers could get lung cancer.
Yeah.
So it wouldn't have been something that I really would have gone to.
Yeah.
Yeah, I mean, if I know now 10 years down the line what I know now, I would have definitely gone to it, because I'm concerned. I'm concerned like anybody about your health. I think the screening for any sort of cancer is important. And if I'd known that never smokers could get lung cancer, I would definitely have gone and wanted it. And even if I'd continued to cough and even my situation, I'd have kept going back and saying, could I have never smoked lung cancer?
Yeah.
But I didn't know about it at all. And the thing that's interesting is when I'm a member of the ALK Positive UK group and the worldwide ALK Positive group. Within there's like consultants with ALK Positive lung cancer. There's GPs, there's nurses, there's physios, there's OTs, there's technicians, and they didn't know about never smoker lung cancer. So I would imagine that a lot of people who haven't smoked wouldn't think that they're going to get it. I really would, yeah.
So
and I did ask actually on the ALK pages and said, did you know that never smokers could get lung cancer? And this was on both the worldwide site and the UK one, and there was over 80% of people said no, and the ones who said yes related it to asbestos or radon or working in some sort of hazardous work environment. And one person said that although they knew about different causes of never smoker lung cancer, they didn't realise that there could be an unknown cause for it, which I thought was quite interesting.
Yeah. So what I'm hearing there is that you kind of think this incentive would be absolutely, bite off the hand for taking up with those self-referral chest x-rays, but there needs to be that public awareness campaign speaking to the fact you only need lungs to get lung cancer. And I mean,
I think yeah.
Yeah.
I think unless people are aware that never smokers can get lung cancer, you wouldn't really get them.
Yeah.
I might be wrong. I don't know the people who have never smoked have been picked up via the current scheme or not, but have they?
Yeah.
Oh,
And
that's
you're quite right. There's such a big education piece for everybody, and that's about the same. We always have to appreciate that tobacco smoke is the leading risk factor for lung cancer. That the single greatest thing that anybody can do if they smoke is to stop for their health. It's incredibly challenging, but there's loads of effective treatments out there to do that. And that if they have symptoms, what we've talked about, cough, breathlessness, chest, back pain, 3 weeks or more, it has to be investigated. But at the same time, if you have lungs, you can get lung cancer. The chances are incredibly small. They really are. But it's there. And there has to be a vigilance for symptoms that aren't going away. Exactly the same rules. That 3 weeks rule needs an x-ray. Even if that x-ray is normal, there's got to be that vigilance that if things just aren't right, not explained, not getting better, it absolutely needs investigating further to find that one.
I think the profile of lung cancer is changing, isn't it?
Yes.
So I sort of saw it as people who'd smoked, a packet of cigarettes a day for 20, 30 years. And then they got to the 70s and 80s, and then they were diagnosed with stage 4 lung cancer. That was my sort of rough perception in my head. Then now, having been diagnosed with lung cancer and not fitting that group, I realised that never smokers are a totally different group of people. And, I know somebody who was 17 when she was diagnosed and then went on to do a nurse training after she'd been diagnosed. I know people in their 20s who've been diagnosed, people in their 30s, people who've been pregnant when they're diagnosed, people with very young children. So there's people from the profile is changing. So it's actually getting that shift, I think, in healthcare professionals and the general public's head that any age of I mean, 17 is the youngest person that I've met, but obviously I don't work in that field, but just from the support group I'm in, it's covering a lot wider age range. So.
And that's the thing. I think in your head, having that archetypal type A smoker, I mean, it's what I grew up with, and I think a lot of people did. And it's not only, I think what you've said there is correct. It's a two-tiered approach. It's not one or the other. It's both healthcare professionals and the general public. The general public need to be endorsed and educated, and the healthcare professionals need to be aware of this kind of profile of person that is eligible for these treatments, because I mean, it's happened in the past kind of however many years, and it's so important for your group to be represented, because like Matt said, is it the 6th? If it was on its own, it would be the 8th numbers. That it would be classed as the 8th most prevalent, or
so the 8th commonest cause of cancer death.
Crikey. So, having that advocacy and understanding that it's that change of mindset is so important.
And people regularly post when they join the group, and you get people who are marathon runners, people who cycle, 100 mile long distances each week, people who do triathlons, There's people who've worked in cancer research who come through who've no idea that it exists. And then within the field of people working within that field, there's lots of developments going on. The treatments are changing. And, for me at stage 4, the treatments just changed as I was diagnosed, which was great. And I was given 10 months to live. And because I've responded well to treatment, I'm still here. But now there's treatments coming through because of genomics and genomic testing and biomarkers. And there's treatments coming through for people at stage 1, 2 and 3 with never smoker lung cancer. So
yeah, it's great to hear. And for those of you who haven't listened, definitely listen to the Out Positive episode with Fabio, because it kind of nods to some of those things that you've just talked about. So I mean, coming to you, Matt, what would be your hope for the diagnosis of kind of symptomatic lung cancer in not only Manchester but kind of nationwide over the next, we'll give it 10 years. I think 10 years is a good expanse to go by.
Well, I think the ambition is to never hear a story like that again.
Yeah.
Through a multifaceted strategy that does try to drive up public awareness about non-smoking lung cancer, about the need for investigation in persistent symptoms, through healthcare education, through new ways of delivering healthcare, like self-referral. That's just one of them. There may be numerous other things that work, and as I say, the focus is really now shining on this area. Lots of areas across the country doing some really innovative work. So we try and learn which of these things work the best and is going to help us achieve that goal.
So would you see the self-referral x-ray? I know that's kind of one of many things that are going on, but that's just in Greater Manchester at the minute. Would you like to see that rolled nationwide? Yeah,
and there are other services, and some that have run before the Greater Manchester one, but I do really think that's a key part of it.
Okay.
And I think our results really show it's the uptake, particularly against other ways of increasing X-rays that have been tried before. I think it's a really powerful vehicle, one of others, but and that's as the Cancer Alliance in Greater Manchester. That's what it's charged with. It's charged with innovating and understanding what interventions work well, and then trying to make them business as usual.
Yeah. And if you had a policy request to address some of the barriers to these incentives being introduced, it's quite a hard question, but do you have a policy request that you'd kind of like to see implemented?
I think it already is. I think it has the attention and the appropriate level of focus. Going right back to where we started the conversation about the horror of lung cancer, and the effect it terrorizes communities. It really does. And so it rightly has the focus. And there's so many things happening about screening, about better treatments. This is the unmet need. It's that making sure somebody with symptoms gets the appropriate care that they need and knows what that appropriate care is and where they're empowered to get that care. So I think it has the attention. I guess my plea would be for it to address every aspect of it, not just one.
Yeah.
And I think that's really coming up, particularly in what Sally said.
Yeah.
That it's on every angle. We've got to create almost a new persona of lung cancer, because we have, wrongly, but if you say lung cancer, perhaps we could be guilty of thinking of a male in their 60s or 70s that have smoked for a long time, often from the communities that face the biggest financial challenges. But it's not the case, particularly in never smoking lung cancer, which is younger people, perhaps more common in females, from more affluent communities. We've got to understand that there are different faces to lung cancer and recognise that.
And do you think maybe governmental public health campaigns, like, you know, your kind of TV ads and the kind of billboards and things would help assist with that?
Yeah, there has to be good media campaigns that raise awareness, and I think it's a really difficult balancing act. We have to listen to people that have been through this, and listen to how can we best get those messages across. It's really important for somebody to know that anybody can get lung cancer. I'd never want it to feel that the risk of lung cancer is a very powerful motivator for somebody to stop smoking. And for that person to hear a message, it doesn't matter whether you smoke or not, you can get lung cancer. Would never want that to be interpreted as a message that doesn't support everything that's being done to stop smoking. So you've got to get the balance correct, and listen to every community to understand how do you best deliver those messages. We have to stop as many people as possible from smoking, from ever smoking, or if they do, to help them to stop. We have to make sure everyone knows that you could get lung cancer. You could. And to be vigilant and to be persistent and be empowered to act on those symptoms. So I say it's a challenge. There's not one solution.
No.
But I do think the focus is on it rightly now.
Amazing. And I guess that's where you come in, Sally, and the advocacy and patient groups that you're working with, and communicating the messages that you would have found helpful for the cohort that you represent. And that's so empowering and really, really beneficial as well.
Yeah, I mean, I can see that. I mean, obviously, I can see that awareness needs to be raised about never smoke or lung cancer, and I can see the problem with people who've smoked and not wanting to stop them going for screening. So I can definitely understand that. And you wondered if you could have like a campaign with 85% of people who get lung cancer have smoked, and then have pictures of them, and then pictures next to them with the 15-20% who, like somebody said the other day, I was 26, they never thought I'd got lung cancer. So if you had, obviously the bigger percentage is people who've smoked, and they need to get the right treatment equally as never smokers. But there needs to be some awareness that the age range is so different, isn't it? And the things like the screening program only seeing people over 40. How do younger people get picked up? I think.
Yeah, I mean, Ruth Strauss Foundation actually did something with Rankin, the photographer. I'll put it in the bio for everybody that's interested. It's these patients holding up, I think it's their CT or their X-ray scans, and it just shows the plethora of difference of what your archetypal lung cancer patient, in inverted commas, would be. So I'll put that in because that's so interesting. But for that message to be disseminated to a greater extent would be.
Yeah, I mean, that was a really good campaign.
Yeah.
And it's really good that Andrew Strauss is actually set up this charity to raise money for never smoke or lung cancer, and to promote and raise awareness about it. And it would be good if that campaign could be spread wider.
Yeah.
And the EGFR, which is another mutation, which is a lot more common than the ALK that I've got, their group was also involved in that.
Yeah.
And I know some people actually... on those photographs. So.
Oh, crikey.
Yeah.
Yeah. Well, it's good that you've got a nice community as well, and forums as well that are enabling you to kind of speak to all these different people.
I think that's sort of developed since I was diagnosed.
Yeah.
It's the Worldwide group came about, and then the UK group. Yeah. So it is good.
Oh.
Yeah, and they do try to raise awareness to people. Well.
Yeah. So nice. Well, thank you both so much for speaking with me today. I'm just wondering if you have kind of a leaving message, Sally, that you'd just like to say on, why you kind of came, just that leaving message. Because it's been absolutely fabulous to hear your story. And I think, like Matt said, it's completely harrowing, but I'm really appreciative that you have got the kind of strength to tell that story, because it's so beneficial in this conversation and other conversations, and including that patient voice. And you've been fabulous. So honestly, thank you so much. But it was just...
I think you only need lungs to get lung cancer.
Yeah.
Is a big one. And about the changing profile that, the profile for never smokers is totally different than for smokers. There's a lot of research going on and treatments and people living a lot longer. I know people with my type of lung cancer who've lived for 16 years, and one who's still alive after 16 years. Some people aren't as fortunate as I am very fortunate, and some people are obviously a lot less fortunate than I am. So genomics has sort of moved things forward an awful lot for never smoker lung cancer. And I think screening and health education are just so important.
Yeah. Amazing. Thank you. So yeah, we've heard about Sally's story. We've heard about the self-referral chest x-ray and the hopes to integrate AI into that. We've heard about kind of public campaigns that would be beneficial, and finally hopes for the future and a little bit of a policy request. So thank you so much, everybody, for listening. Thank you, Matt, so much. Absolute hero. And I know GM Cancer are doing amazing work, and it's great to hear about it. And unfortunately, we don't have the time to cover it all, but we just have to pick your brains for one of them. And massive, massive thank you to Sally. I'll include all the links in the show notes, but for now, I guess it's goodbye. Following the recording of this podcast, Sally Hayton recorded an additional message that she wished to include to contextualise her positive experience since her diagnosis and her treatment at the Christie in Manchester.
I must say my experience before diagnosis has been very different than my experience since my diagnosis. I've been a patient now at the Christie for over 10 years and feel very fortunate to be treated there. I have had excellent treatment from my oncologist and other staff there who have the clinical expertise in treating never smoker lung cancer. I feel very fortunate to have been diagnosed just as cutting edge treatments were coming through. All of the medications that I've been treated with have been through clinical trials at the Christie.
If you have been affected by anything you've heard in this episode, please see the show notes for a list of charities and organisations that can help.
1 in 2 was brought to you by the University of Manchester and the Manchester Cancer Research Centre. Listen to our next episode to hear from more of our researchers as they share the innovations, discoveries and projects that are changing the landscape of cancer prevention, early detection and treatment. To find out more about what you've heard today, please see the show notes for this episode, where you'll find a transcript and links to further information and research. Cancer is one of the university's 5 research beacons, showcasing the interdisciplinary collaborations and cross-sector partnerships that are tackling some of the biggest questions facing the planet. To hear more about Manchester's research in advanced materials, biotechnology, cancer, energy and global inequalities, go to manchester.ac.uk/beacons.